Yeah, I see
It
you, Dr. Hackett. Yeah.
is a genius. She wiped something off my monitor.
Well, good afternoon, everyone. Thank you so much for joining us on this Friday, May the 20th, 2022, for the Flint Community Webinar on Coronavirus. This is our 104th week gathering together to talk about how we can take a global pandemic and bring local context to it. This webinar today is being brought to you by the Healthy Flint Research Coordinating Center, which, as I'll remind you, is a community academic partnership. We're working together with our academic partners to try to really understand how we can facilitate quality research and help bring an understanding to why the research is so important in our community and how our community members can be involved. Also, the Flint Center for Health Equity Solutions that brings to us good information about the equity data conversation and what we need to, the issues that we need to elevate and have a greater understanding of. And of course, then the Michigan Prevention Research Center, which we're also looking at how we can engage our community members in community academic partnerships through community-based participatory research. It is exciting to be your moderator today, Yvonne Lewis. And it's so interesting as you wear a number of hats in the community. One of those, I am serving as a co-director for the community core of the Healthy Flint Research Coordinating Center, along with other projects that we're doing in the community. It is so wonderful that every week we have an array of community partners who join us to help us really hone in on how we understand what's going on with this pandemic. Again, just as a reminder, we're still in the midst of a pandemic. It's happening globally. That means somewhere around the world, people are affected by the coronavirus. But we wanted to be sure that our local community organizations, agencies, providers had an opportunity to talk to us as community members about what's going on and help us to understand the resources and services that are available to ensure that we can provide the best absolute information to our community as possible. As you've heard over the years, there's a lot of misinformation, one of which is maybe the pandemic is over. But one of the things we want to note today and just take a pause for is to understand some of the things that we're going to be talking about today. We kind of every week bring to you some interesting information. And so our topic today was a little bit interesting. And then one of those topics is what your spit can tell you. And I know some people might be wondering, what does that mean? But there is really important information you're going to hear today from our two special guests, Dr. Lipton and Dr. Vega, about what our spit will tell us. We'll also have an update from our Flint Center for Health Equity Solutions about some of the trends in the data. We've got an update from the city of Flint, and we're going to also have conversation with our Genesee County Health Department. Today, I want us to take a pause, however, because we have now been 114 weeks talking about this, which is a little bit over 2 years now. And we want to recognize and take a pause to think about the 1 million individuals that have lost their life as a result of the coronavirus. We have so many inequities happening in our community. And one of the things you'll hear today is how this has created an even greater challenge for us in our community. We cannot forget that this is a really, really important issue, and it requires all of us to take note and think about how we can make better decisions based upon the information that we have in order that we can have a healthier community. Let's figure out how we can reduce the number of individuals who are passing away from this virus. And one of the ways we'll do that is really understanding how we can contribute to the work that's being done. I think we've mentioned to you, we're all in the midst of a great big research project, whether we want it to be or not, we're in the middle of it. So I want to welcome our two guests today, Dr. Lipton and Dr. Vega, who are from Michigan State University. And I had to really think about this and how this made sense. And they'll tell us they're in the Department of Translational Neuroscience. And they're talking about COVID. So I want to just have them come forward and join me in a quick chat today, Dr. Vega and Dr. Lipton. You've been on a journey in this, and I think you mentioned to us earlier, Dr. Lipton, who ever thought you would be talking about COVID right now. So tell us a little bit about how we got started here. And just as a little bit teaser, we said spit, but you're talking about saliva, and there's work that can be done to help us understand how our saliva can give us insights on the coronavirus. So I'm just going to hand it off to you, Dr. Lipton, to get us started.
Just to answer thank you, Ms. Vaughn. I appreciate you having both of us here. Just to answer your question about how a couple of translational neuroscientists got involved in COVID. We started actually working on developing a test back in March of 2020 to get our own research labs back open and seeing what we could do, because we knew there was a testing shortage, and PCR testing, people have heard is the gold standard. Even if you don't know what it is, you've heard of it. And we do PCR testing all the time in our labs as we use it as a tool in research. And in the process of working on this and developing a test, we ended up getting involved nationally in trying to get universities involved in testing to keep it, not only focused on clinical laboratories that kind of had a monopoly on the testing. So we had some op-eds out. We started to develop a test. We tested the tests, sensitivity in community clinics, and Irving was really critical in getting out to locations in West Michigan to help not only have us perfect and test our test, but to help medically underserved people who couldn't get access to tests, because it was so hard in the beginning of the pandemic to get access to a diagnostic test. So we started doing that just because we started working on it for our colleagues, and then we ended up developing a program that ran at Michigan State University, and we've run hundreds of thousands of samples and developed new testing schemes. We never thought it would happen, but here we are talking about COVID. Now we're COVID experts.
So tell us what this spit piece is all about. And I thought it was kind of interesting. We tried to figure out, how do you help people understand? If we said saliva test, what does that mean?
So one of the reason that we started getting into saliva as a testing medium, instead of the swabs that people were getting shoved up into their brains. Also, neuroscientists always thinking about things getting shoved into people's brains, probably not a good idea. There was a shortage of swabs for doing those kinds of tests. And so we tried to figure out what's an easier way, a more simple way to do that with the materials that we had available to us when there was such a shortage on these particular instruments for collecting samples. And so we started to develop our own saliva test. People were telling us not to do it, that saliva is not a good choice, that it starts in the nose. You should, the sensitivity of tests is going to be better if you're taking it from the nose. And ultimately, what has been found out is that it's actually at a higher concentration in saliva. Several other universities started doing saliva tests. We developed ours around the same time that Rutgers did in New York. And ours is only used locally, but the Rutgers saliva test is used nationally. So it ultimately ended up being a good choice for us to be able to use the things that we had on hand to be able to test. And it gives us a lot of material, and we can test the sample more than one time. So we can confirm a test, we can then send it off to understand the genetic code of the virus. There's lots of things we can do. I can, hopefully.
So you've got a great presentation for us, and you mentioned that genetics. So you'll explain to us how this all works. Thanks, Jack.
Okay, so let me, hopefully I can get this thing started appropriately. Okay, can you see my screen?
Yes.
Okay, so hi everybody. Thanks for having us. You know who we are. We've already been introduced. And we've talked about translational neuroscience, so we're all bored with that already. So let's get going. So really what we want to talk about is 2 years into this pandemic, why is COVID-19 testing and so important, and why is understanding about viral variants so important and critical to our health? So I'm going to lay out what we're going to cover today, hopefully briefly. I'm going to give a little background on testing, some of which I may have already answered. Talk about what a viral variant is. You hear these terms, alpha, gamma, delta. We'll talk about all those. Why do they matter? What's the difference between the variants? How have the dominant variants that we see in the community change over time? And then Irving is going to talk a little bit about the consequences of racial and ethnic backgrounds and how they influence the incidence and severity of illness, and other contextual factors. And does all of this still matter more than 2 years into the pandemic? So just as a quick background, which Yvonne mentioned, we developed a test starting in March of 2020 and went through it pretty quick. We developed an assay in March, optimized it with contrived samples, which means we kind of developed our own fake samples to test our assay. We worked with humans in April, got our first sample from an employee of MSU Extension, who was the first person that we knew that had COVID. We started community testing. Dr. Vega really helped us to get the testing out into the community so that we could compare our tests to existing tests. We published our protocols, started optimizing for saliva testing in May. That's when we moved from nasal swabs to saliva. We developed a task force at MSU. They drafted us into developing a university-wide program where we pooled samples to save money and save materials. We were approved to proceed with a university-wide program in June. We piloted it in 2 colleges, the College of Human Medicine, which we are both part of, and the College of Vet Med. And then we developed a lab from Grand Rapids over in East Lansing, an hour away, which took up a half of a floor in a new building. And we started running tests on September 11th. So that was our nightmare of a few months trying to get this working. And so what do? Our test is pretty simple. If you look back here, we have a picture. This is our spit kit that we developed. And it's a box. It's got a big tube that you spit in, a little pipette, and we take some of your spit and move it into this smaller tube, drop it into a biohazard bag. And that's the basis of the test. It's a couple of bucks to create the test. So people spit into a tube, we mix it with a preservative, and then we amplify it and we look for whether the person has COVID or not by looking for the presence of the virus in their saliva. We are then going to be using that and I'll talk about this a little later, in our new program. So what did we end up producing from this program when we started? We've conducted a total of almost 278,000 tests for the MSU community, and we detected 3,600 cases of COVID-19. We developed a really cost-effective kit. That kit cost $3, and the way that we run the PCR test cost around $8. So it was very, very inexpensive, which was really important. A lot of companies are charging $100 per test, and we were able to do it at a very low price. One of the most important things that we did at MSU was to keep people employed and train a new generation of laboratory scientists. So we developed this lab and took new college grads and other people who weren't college grads to work in the lab, help us assemble and develop our spit kit and conduct testing and distribute the kits and get us our samples back. And then we took this and demonstrated the scalability of this test for use outside of MSU. And in fact, that's what we're doing now. This next phase of our program, which is from a grant that we received from the Michigan Department of Health and Human Services, which comes from the Center for Disease Control, ultimately the parent funding, was to use this program that we developed, which is called the Early Detection Program at MSU, and use the infrastructure of it to sequence viral material from people's samples and monitor variant emergence. So we're looking for variants of SARS-CoV-2 or COVID-19. We were originally doing this for MSU students, faculty, and staff, but our program, the Early Detection Program, ended on May 13th, my birthday. And now we are focusing more on community collection of samples. So we are collecting samples in West Michigan and in Flint. And so Irving is really in charge of coordinating the samples that we collect in West Michigan, and Heatherlyn Uphold from the Division of Public Health is really coordinating for the Flint community. We have another project which is also of interest, just to give you some information about what we're trying to do, which is continuing to sample from the same people over and over, people that are immunocompromised. So these are people that might have a problem clearing the virus. And one of the things that is a big theory out there as to where some of these viral variants come from is that they come from immunocompromised people who might have the virus in their bodies for a long period of time. So we're going to take samples every day from immunocompromised patients that are infected with COVID-19 to see if the genetic code of the virus that's in their body changes over time. And then we're also, through the vet diagnostic lab at Michigan State University, we'll be monitoring animal populations to see if when the virus gets into pets or into wildlife, if it doesn't mutate in specific ways that may end up producing variants of concern for us as humans. And then we're going to take the information that we have and share information about the emergence of variants. And then we're trying to encourage vaccination and testing through our partnership with the NNICE program, which is the National Network to Innovate for COVID-19 Vaccine Equity, which is centered right there in Flint. And Deborah Verholden was the leader on that. And then, of course, there's a ton of other people who are taking up the mantle on that program. So let's talk a little about what a variant is, right? So what is a viral variant? So variants of viruses occur when there is a change or a mutation to the virus's genetic material. And so there's a picture here that you can see. The virus has its genetic material, which is RNA. And that's what this little picture of a coil is. It has these little red spikes on it. So this is the spike protein. And so the change that can happen in terms of the virus, and you can see it's colored in different places. So we have the nucleocapsid, which is the envelope, the circle that encases the genetic material of the virus. We have the red things, which are the spike proteins, and then there's other bits of the genetic sequence that are important in the development of these viruses. The nature of these types of viruses, these RNA viruses, so they don't have DNA like you and I have for determining their genetic makeup. They have RNA, and we use RNA in our own bodies as well. But these viruses are made of RNA, and RNA viruses in general evolve and change gradually. One of the important things to know about variants is that once you've been exposed to a virus, your body understands what it kind of takes a snapshot of that virus. And so it understands the outside of think of it like a wanted poster, like in the Old West or something. Put up a wanted poster, or America's 10 Most Wanted, and there's a picture, and your immune system is kind of the guard to not let those pathogens in. If that picture changes a little and it looks a little bit different, your body doesn't necessarily recognize that foreign invader into your body as the same thing that you were infected with last time. And so the reason when those things change, when the variants become significantly different, your immune system is not able to catch it, and it can reinfect you and create a breakthrough infection, even if you've been immunized, because it looks different. The contagiousness of the disease can change, the transmissibility. So how easily the virus spreads changes, and the severity of the disease can change. We know early on in the pandemic, people were getting very ill, and we know that the new Omicron variant, even though it spreads very fast, doesn't produce the level of hospitalization and death that we've seen previously. Whether that's a result of people's immunity changing and the level of immunization, or whether it's the virus's dynamics and its ability to produce a severe infection, we're unsure. So let's talk about the transmissibility, which I think is really important when we think about our communities. The original virus had what's called an R0. So they use this term for infectiousness of about 1, which means that on average, it would infect 1 person from an infected individual. And then those numbers ranged from 1 to 3. So the original virus had about 1 to 3 people that you would probably likely to infect. But as the variants came along, and here's alpha, I was infected with alpha, which is nice to know that I have a sequencing lab that can tell me. And this was back in April of 2021. Alpha is more transmissible, and on average, it would infect 4 to 5 people. Delta, which we've all heard about, Delta was produced a huge wave and a lot of deaths in the United States. You would on average infect 6 to 7. And then Omicron, which is the newest one, there's 2 subvariants of that. The first one was, well, there's more than 2, but the 2 dominant ones are BA1, which would infect about 7 to 10 people, and BA2, 8 to 12. So you can see how much this has changed in just 2 years. It's really shocking to see how much more transmissible these variants have become over time. And here, this is just to show how, kind of what the timeline looks like. So Alpha, we started to see it in the UK in September of 2020. Beta, which really never was a variant of concern, but really never took hold, was also in May of 2020. It came from South Africa. Gamma, which really didn't take off, and I'm going to show you another image on this, was November of 2020. Delta, which is really a star variant after Alpha, was October of 2020. So all of these, you can see, were developed pretty early. And then Omicron came in November of 2021. So think about the amount of time between then and now, and Omicron really came on fast because it was so transmissible. And let's take a look at how those have changed over time. This image really highlights the four that we're talking about, the original here, and this is week by week. So we have back here, this is in 2021. What was the proportion? As you can see, when we came into the beginning of 2021, most of the virus that we saw in our population going from 0 to 100% here was in this dark blue, the original virus. But you can see over time, over a few months, Alpha really started to take over in 2021 and became the highest proportion of the virus by the time we hit May. And then Delta, which was even more transmissible than Alpha, really took over. It started to appear in May and June in significant amounts, but just in 1 or 2 months, it became the absolute dominant strain in the United States. And then even more impressively, we thought if Delta was bad in terms of its ability to transmit, Omicron, you can see the real steep change from absolutely all Delta here in November to, by the time we got to January 1st, almost totally Omicron. It went really, really fast. So understanding what variant is running around in the community, what's predominant, understanding how it spreads from one community to another is really valuable information for us to understand what we can do, how we can keep communities informed, and how we can understand the behavior of these viruses, the types of disease that they produce, and give everyone all the tools in their toolbox needed to mitigate or minimize their ability to spread the disease. All right, Irving.
Yes. So this virus induces the disease that we know as COVID-19. And the burden of COVID-19 has been felt disproportionately in the communities of color. And this slide illustrates, was published in May 11 of 2021, the distribution of the proportion, I should say, of cases, hospitalization, and death based on race and ethnicity backgrounds. And what you can see in comparison to whites that are the gray bar and normalized to 1 is that Black, American Indian, and Hispanic have shown more cases, more hospitalization, and more death than whites. And that is at the level of the US, and is the disproportional presentation of the COVID-19 disease within this community, and in particularly, and unfortunately, the deaths associated with this disease. At the level of the state in Michigan, if we look at what happened early on in 2020, we saw also that national disproportional relationship in terms of the burden of COVID-19 represented or affected also our communities of colors in Michigan. In the west side of the state, you can see that it's more the Black community was in the east side, more of the Black community, and in the west side, more of the Latino community. And the disproportion is what is known, the disproportionate representation of a disease is known as a disparity. And we as a community of color, Latinos, African American, Black, already have different diseases that are disproportionately represented in our community. Diabetes, high cholesterol, hyperlipidemia, asthma, Alzheimer's disease, that is what we study in the lab, are disproportionately represented in this community. And as you remember, COVID-19 was also affecting more severely people that have these diseases. The root of those other diseases that make us more vulnerable to have us to be in the hospital and actually, and unfortunately, to die, we're putting ourselves more at a risk of these severe outcomes. And additionally, other structures that we're going to talk in a second. But this is not only, unfortunately, this is not only in adults, it's also in children. As you can see in the next slide, this one is from January 15 to January 22, where you can, as Dr. Lipton mentioned, was the Omicron variant. You can see the distribution in ages from 0 to 4 up to 16 and 17 years of age. And in comparison of white, you can see that this group of children, children are more affected than whites. And you can see also disproportional differences in the age group, where blacks 0 to 4 years of age are more affected. And when you look at the Latinos, 16 to 17 were the most affected age group. This disproportionality of COVID-19 among communities of color is not because our biology makes us more susceptible to be infected by the virus, or we are genetically different to any other group, and that's why we are more infected rapidly or getting a disease worse. What the data says, and in the next slide, it shows some of the papers that were published, illustrate that is a structural racism in healthcare and the difficulties of access to healthcare that made our communities more vulnerable to severe outcomes than any other ethnic group. In addition to that, when you look at the labor force, people of communities of color were more represented in the service industry, in the food industry, that were also cataloged as essential workers. And they never have the privilege to work from home. So they not only had this history or have less access to healthcare and for that reason have worse health outcomes, they also were disproportionately exposed to the virus due to the workforce and the representation in workforce that they were not shut down during the beginning of the pandemic. So that is structural disparities that make us more at risk of different diseases and poor health outcome. COVID-19 just took advantage of that and made us and made and affect our community in an addition to already some of the health problems that we are disproportionately affected. So why we need to continue still testing? So in the next slides, I will give you few reasons, and we can discuss other ones of why we still need to, why testing is still important. One is that once you get the positive test, you can do that timely and you can receive timely and appropriate treatment. So in that way, you can avoid worse outcomes and perhaps prevent you to go to hospitalization. But importantly, there is something that is recognized right now as the long-term effects of COVID-19. And different states are already developing long COVID-19 clinics because it's known that there are different symptoms that lag for weeks, months, right now until 6-8 months. And there are people that are still over a year still feeling some of the symptoms. And these are highly represented. These symptoms are fatigue and also headache, psychiatric or emotional problems, And we still don't understand, and it's something going back to the original question of why neuroscientists are working on COVID-19. COVID-19 definitely is affecting the central nervous system. And there are people reporting anxiety, depression, sleep disorders as part of the long-lasting effects, without mentioning the lack of taste and the lack of smell, that it can lag for months after an infection. So in addition to receiving timely and appropriate treatment and be able to talk to the doctor, hey, this symptom that I'm having, it may be still related to COVID-19 and no other reasons, it will be important. Additionally, as Dr. Lipton showed, these variants are becoming more and more infectious. So that means that one person that with the original variant can infect 1 or 2 people. Now someone with the Omicron can infect 8 to 12 people. So if you tested positive, now you can also modify your behavior to reduce reinfection, but also you can reduce the propagation in the community, right? Not only you can identify, oh, it was in this place that I got infected, but what was my behavior that led to that infection? And then communicate with the people that you were gathering and reduce that propagation within the community. By reducing the propagation of the virus in the community, you're also doing your part to protect those more vulnerable in the community. We know that even though vaccination protect people from hospitalization and death, and that's the main purpose of vaccination, people with chronic diseases like diabetes, respiratory problems, and immunocompromised can still, even though if they're vaccinated, they can still end up in the hospital and having some of these long-term effects of COVID-19. So you will be doing your part by knowing whether you are positive or not only reducing the propagation, but also protecting those most vulnerable within your community. And lastly, you can also don't serve as a laboratory for the virus to change its coding, because everyone that gets infected provides an opportunity for the virus to change itself, to gather mutations and generate new variants. So that is that by staying and not infected other people, now you're reducing the chance of passing that potential new variant to another individual. So that's the information we had from you today, and we will be happy to answer questions or engage in a further discussion.
So while you're right there, Dr. Irving, you mentioned this word propagation, and I know you explained it, but can you just give us a everyday definition?
Very good, thank you. So one infographic that Dr. Lipton showed was a variant with individuals, 1 to 3, 5 to 7 to 8, 8 to 12. So one individual, that one, thank you. So what that graphic says is that the original variant, the original virus that causes COVID-19, one individual infected can infect 1 to 3 individuals, right? But then imagine that you, unfortunately, don't know that you're positive and you infect 3 individuals. Then those 3 individuals can infect, each one can infect 3 individuals. So now from 3 individuals that were infected, now you have 9 individuals infected, and then you have 27 that are infected, and then you continue, and that is the propagation. So it continues that capacity of propagate. Imagine now when one individual can infect 8 to 12, then those 12 that were infected can infect themselves. Each one can infect 8 to 12. And in that way, you keep propagating, you keep spreading the virus to the community from one individual.
Thank you. I'm going to ask Dr. Hackert and Dr. Wolford to join us for a quick few minutes in this conversation. Dr. Hackert is our health officer, and I know Dr. Wolford works at U of M in the pediatric unit at the U of M, and we talk a lot about these precautions and how do we stop it. So that message continues. So I just want you to give us some insights, and maybe you have a question or two for our special guest here. Dr. Hackert.
I really enjoyed the presentation and had already asked if I could get copies of the slides. I thought it was very well done, and particularly in terms of being able to visually see some of the more complicated things you're discussing. I thought you explained it very well. So in terms of what can we do with this, I mean, obviously, as the cases go up, if you have potential exposure, you will be able to protect yourself. I don't know if either Dr. Lipton or Dr. Vega would want to comment on some of the studies that are showing that use of mask wearing can actually reduce the intensity of the illness as well, because you have a lower viral load coming through even if you get it while wearing a mask. So I thought that was an interesting article. But I think this is the time we want to also remember that there are things we can do. You know, we have two different types of immune response in our bodies. One is the innate system, and something I think is just kind of fun is that, you know, the researchers and the medical doctors named this one of the important cells in that natural killer cells. I thought that was very, you know, whimsical to be able to call it natural killer cells, and that's what people are talking about. But your innate immune system is what you're kind of given with it. When people talk about, I want to build my immunity to protect myself against this, yes, you can, and it can help. It's not going to help in all situations, but as we know, if you're immunocompromised, you have additional risks involved. But you still can do some things, and there are, you know, this is where the sleep, the healthy eating, the exercise is critical for building your immune system. Also the healthy weight, which I've been trying to work on myself. But there's a few little controversial things, you know, it's like, let your fever, if you do get it, let your fever go up to about 102 before you start trying to bring your fever down, because that can increase your immunity, it increases your level of defense on that. And so those are just a couple of things that I've been thinking about that we need to work on building those things up while we have the time this summer, while our numbers are still moderately low.
Thank you. Dr. Wolford.
Well, I just have to agree with Dr. Hackett. That was spectacular, just awesome. Been thinking about all of the variants. One of the things I heard recently, and I wondered if you knew more about it, because as you say, the variants change, right? And so their characteristics change. And so it's sort of like you have the parent and then the child and then the grandchild, and they're similar in many ways, but the grandchild does have some differences from the original, from their ancestors. And so with that, I wondered, the more recent variants, the time in which you are more contagious seems to be different. Like in the beginning, maybe you were more contagious earlier on. So once you started showing symptoms, you were already beginning to maybe get close to where, okay, maybe at 5 days out, you won't need to isolate anymore. But now there's some suggestion that you're becoming contagious somewhat after, or more contagious. The peak of when you're contagious is somewhat after you start having symptoms, which will then impact how long one needs to isolate. Do we know anything about that, and anything about that for our communities?
Do you want to go, Irving, or so I do know that
you can start and then I can
okay.
jump in.
so there are differences, right? The time frame on the development of the infection and the dynamics of how much viral load you have in your body does change over time, and the compartments in which it is changes over time, right? So originally it was a lot of nasopharyngeal, definitely focused on the nose. The development of the virus in saliva was a little bit later. And now early on, saliva seems to be front loaded in the newer viruses and the newer variants. And then of course the time frame. I do know, I'm not exactly sure on when the peak is with Omicron. So I can't necessarily answer that. I do know that they have been giving people advice to wait on their antigen testing, because those tests are generally less sensitive than the PCR tests. And so the goal is to ensure that if you have 1 or 2 shots with one of those tests you have at home, or even if you're using it in a community clinic that uses antigen tests, that you want to make sure if it is positive that you're seeing it at the right time. But that doesn't mean that people shouldn't be isolating and following the appropriate public health measures, as Dr. Hackert mentioned as well. But yeah, I don't know. What do you have, Irving?
Yeah, so I know Dr. Hackett has her hand raised, but I want to just add to think about the biology of the virus, right? So the virus is changing, and the how infectious the virus is changing with those changes that are being incorporated. With the Omicron, what we learn is that you need less particles of the virus to get infected. So it's more infectious. The spike protein that Dr. Lipton was showing has changed in a way that it can be uptake by our cells faster. And will that require less particles? But this is in the context that most people, or a lot of people in the community, are vaccinated. And one of the questions people say, but why? If I'm vaccinated? Well, the virus is responding to that force, and it's trying to find a way to go through those defenses that we are providing, right? So the way I illustrate this in the community is by a soccer game, right? You have, at the beginning of the pandemic, a very good soccer team without a goalie in the other team. And they were scoring like crazy because you didn't have a goal. Then you put a good goalie there, and now you have the same team, and now that goalie is blocking all the goals. So the manager of the soccer team was said, oh, let me recruit Messi, or let me recruit the best players. And now, once in a while, the goalie is good, but Messi is really good. So now they can hit one goal instead of 20 goals. And, the virus is like the manager of the team trying to recruit best players so that they can score on our community. So
I love the football analogy or soccer analogy. That is awesome. Yeah. I have one other question, but I think Dr. Hackett had a comment.
Dr. Hackett, we got a question in the queue, and I knew we would never get done with this conversation today. So we're going to have to ask our team to come back, but let's hear Dr. Hackett, and then we'll get back to it.
Thank you. My question is about the antigen tests versus like the PCR test. So I am reading, and I am also feeling that I have seen enough examples of where you can have like literally an at-home test that's negative, and then you get the PCR test later that day and it turns out positive. So how effective are these tests now that we have at-home testing with these particular variants? I'm not really able to get a good article to qualify that.
Well, I think you're dealing with a couple of issues, right? You're dealing with the general sensitivity of an antigen test. So the antigen tests are based off an antibody, right? And it's stuck on a piece of paper, and you're incubating it, and it's changing some colors. They're generally not as sensitive, and I think that their detection rate is usually in the 80%. And then we have the added complication of having a non-medical professional taking those samples, and adherence to the process of doing those tests when you do them at home plays into this as well. You can easily not have a sufficient viral load to show up on an antigen test, but if you sent it to us for PCR, we're amplifying the material over and over. We double the amount of signal every time we heat and cool the sample, and we do that 35 times. and we can get a really, really sensitive read on that. On the other hand, we can also, the PCR test is very sensitive, and we can see viral particles when someone's no longer infectious. And so we do have to be careful with respect to the sensitivity of a PCR test. You could show up as positive on PCR, where your body's still clearing out bits of the virus after you're ill, and you may not be infectious anymore. So they each have their value. The convenience and widespread availability of an antigen test is great. The PCR test is great for its sensitivity. One of the things that we are doing in our program, which Irving and I have recently changed, is when the community clinics collect a sample and they run an antigen test for patients in the communities, if on their best medical estimate they really think that the symptoms look like they are COVID-19, we ask them to pull a saliva sample for us anyway. And so we want to be able to give that information on how well those antigen tests are working compared to the PCR test. So if we get a negative on the antigen test and we get a negative in the lab, we go, well, the person didn't have it. But if we start to see a disparity in the negative and positive between PCR and antigen, we want people to know that, because new viral variants may not perform as well with the antigen test. And we want to be able to detect that in the community before it becomes a problem, so we can advise them on the use of those antigen tests.
Thank you, Dr. Irvin and Dr. Lipton,
Sorry for taking all your
Dr.
time.
Vega, Dr. Hacker, Dr. Wolfer. I know there are more questions. There are questions in the queue, so I'm going to ask you to look at the questions in the queue. One I do want to respond to about PSAs, and just really quickly, sometimes they don't keep up. You're absolutely right. They're not keeping up with this. As you can tell, even the doctors they're studying, they're making adjustments as they go. So that's why it's important for us as a community to ask these questions, and really, because you are representing to our other community members who may not be here. So thank you for putting those questions in the queue. They're going to look at them and try to make sure we get you some good answers. We've got a few, and we're going to ask Dr. Lipton and Dr. Vega to come back, because if you heard them earlier, they're doing some work here in Flint at our 3 sites, which we'll talk about in a minute. You may go there and they may ask you if you're willing to participate. So now you'll understand why that's so important. So thank you. And we're going to bring up, we talked about some disparity issues, some health equity issues. Dr. Rick Sadler is going to give us a really quick update on where we are based upon the data dashboard. Dr. Sadler.
Yeah, thank you. So some concerning trends in a couple directions. Obviously, as we can all see real quickly, the rates are going up. So these rates per 100,000 are now up to 178 per 100,000 for Genesee County. So that's still outpacing Flint a little bit, which is at 151. Again, that's adjusting for population. One thing that you may not be able to see without it kind of blown up, but so among the new cases in the Black population in Genesee County. So on the left side, the little green bar at the bottom, that's a lot smaller, right? But the percentage of the Genesee County population outside of Flint that is Black is only about 11%. So that's actually a rate that's 3.5 times higher among Blacks in the out county than among Black residents in Flint, or as compared to Black residents generally as compared to whites. So that's a geographic and racial disparity that's emerging. That's just a 1-week disparity, so it's something we have to keep our eyes on, but it could be concerning in terms of you think of the where and who the Black population is outside the city of Flint. So perhaps Hamady, Beecher, Grand Blanc, certain parts of the county, there could be an outbreak brewing there. So it's something we're going to be keeping our eyes on closely. And then, yeah. So, right. So overall, the city of Flint is kind of still middling in terms of its case rates. And so we're looking at monthly case rates in this case. And so for April, you had municipalities like Grand Blanc, Flushing at the very top, Swartz Creek, and then at the bottom, kind of the northern part of the county, Montrose, Thetford, Richfield. And forgive me, I'm blanking if we have a map right after this. We do,
Yes,
yeah.
we do.
Yeah, and so you can kind of see the, like illustrating the general density of cases spreading from March to April. And again, you do see those clusters in Grand Blanc and Flushing. And that's even more notable because there are fewer people in Grand Blanc and Flushing, for example, than there are in Flint the population density is lower. So generally speaking, we would expect to see kind of a pattern if there was no geographic disparities, where it was denser through the middle part of the county and then down a little bit toward Grand Blanc. So the darker shading on the April map shows that the suburbs definitely are having a bit more trouble managing COVID cases than the city of Flint.
And sometimes, thanks, Dr. Sadler, because sometimes it kind of gets a little bit distorted because people so focus in on all the problems are in Flint, but we're transient people. We're driving from Grand Blanc to Flushing to Clio, so we really have to be aware of what's going on overall.
Yep, definitely. And again, that there are more people in Flint. So when we have these density maps, it's not meant to malign the city of Flint. It's again just to illustrate where are those clusters with respect to population, and that's why we adjust ththose numbers for per 100,000 so we can get a better view geographically of where those disparities are. So again, current worst outbreaks: Grand Blanc, Flushing. North County has the lowest case rates, and Flint is kind of in the middle at the moment.
Thank you, Dr. Sadler, for that update. And we do want to pay attention to where these disparities are. So, and I think Dr. Vega pointed out to us, it's not all about just the location, it's also systematic. So Blair Warren is also with the Flint Center for Health Equity Solutions. This is her first time presenting to us today. So welcome, Blair. And you're going to give us even more information about equity.
Hi, hi everyone. I am so glad to be speaking with you all today. I want to make sure I'm spotlit. 1 second. Okay. So I want to begin by noting that COVID is still present and the pandemic continues. It can reach endemic status when the disease is less threatening and more manageable, but we are not there yet. For example, the seasonal flu is considered endemic, and the key is more predictable rates of circulation and less overall disease severity. We need COVID to get to this point, but in order to do that, we need to take appropriate actions to protect ourselves and our communities. Please be sure to get vaccinated, boosted, wash your hands, continue masking, and maintain social distancing from others. Building off of COVID protections, the FDA approved the COVID treatment remdesivir on April 25th. This now includes pediatric patients as young as 28 days old, weighing at least 7 pounds. This is the first treatment that is available for children under 12 years old, and there are some specific eligibility requirements. Patients are eligible if they are hospitalized due to COVID, have mild to moderate symptoms, or are at risk for severe COVID. Also, there's a clear time window for this treatment. The patients would need to receive it within 7 days of symptom onset. So moving on to policy, I have one update that I'll share with you all. House Bills 4674 and 4675 will provide more opportunity for crime victims in Michigan to receive higher compensation to cover out-of-pocket costs, such as medical or funeral expenses, lost wages, therapy, and other resources. These bills will also raise the maximum award possible per victim from $500 to $45,000 and will allow victims allow victims more time to file a compensation claim from within 48 hours of the crime to up to 1 year following the crime. Also, victims will be able to file online instead of in person, and the bills will further acknowledge the impact that crimes have on the lives of Michiganders and provide more equitable opportunity for victims to receive support.
Thank you so much, Blair. Flint Center for Health Equity Solutions policy brief. Be on the lookout for it. It will go out to you and you'll get more details on these comments that were made today. Thank you. Health Department will be represented this afternoon again by Sherelle Brown, who is emergency preparedness educator. Sherelle, there's a lot going on at the Health Department to help us have this information. So can you give us a quick update? And I really want to make sure we spend some time on these locations today for sites that are coming up.
Yes, ma'am. Good afternoon, everyone. So it's been said throughout the presentations that we are seeing an increase in COVID-19 cases within the county. It's continuing to rise. So we just want to make sure that the community does have this information, as well as where to go to get your vaccines. We also want to encourage you all to implement those safe practices like frequent hand washing, utilizing your mask when out in public, and of course, getting vaccinated. We are still slowly increasing our vaccination rates in Genesee County, with over 63% of ages 12 and up having received at least their first dose of vaccine. Next slide. And so we want to keep you reminded of our vaccination sites that are coming up. And tomorrow, it looks like we will be at Mama's Retreat from 11 a.m. to 1. Efforts will be continued from 5 p.m. at the Floyd J. McCree Theater. And then, per usual, at our sites that are set in stone every other week, we'll be at
Figure Central Church of the Nazarene.
Yes, Central Church of the Nazarene next Wednesday.
And then we'll be back at Our Lady. Go back to the next slide, please, real quickly. Yep, we'll be back. First Trinity will be on Thursday, the 28th, next week.
Yes, and then Tuesdays, Our Lady of Guadalupe, and then Thursday from 3 to 6 at Shiloh Missionary Baptist Church. And
we've got some new sites that are coming up for this week too.
Yeah, so there are some pop-up clinics within the community. We're in partnership with Michigan United, which again, they will be out tomorrow from 11 to 1 at Mama's Retreat. And then next Wednesday, aside from Central Church of the Nazarene, there's a Senior Day program at Crossroad Village. So Michigan United will be there from 9 to 2. And then next Friday, they're going to do a pop-up clinic at the South Flint Soup Kitchen from 10:30 a.m. to 12 p.m. And then, as always, you can get your free testing and vaccines at Word of Life Church, Bethel United Methodist Church, and Macedonian Baptist Church. Those dates and times are listed on this slide, and you can find them also on our website at gchd.us.
And one thing we want to emphasize here is Jack's, the program they were talking about earlier going forward, when you may be at one of these sites and ask to participate in that. We'll call it the SPIT study. So,
you can also get testing outside of those sites at your local Walgreens or Rite Aid. We have specific clinics posted that we know are doing those testing and vaccines. And then there's Hamilton Community Health Network on Tuesdays and Thursdays every 10 minutes. If you're unable to go out to any of the sites to receive your vaccination, the health department does have a program where we will come out to you at your home. If you need help with that, you can give us a call at 810-344-4800. We also ask that you utilize that number if you have a hard time navigating our website.
and again, we just want to make sure we re-emphasize the website for those of you that need that data and are out in the community, you want that data. We put it here so that we go back and refer to that, www.gchd.us. Thank you so much, Sherelle. We know you all are out there doing great work. We also want to remind our listeners today that there are some tests being given out again by the federal government. The information is here. 8 at-home tests are being available, and you can call 1-800-232-0223. We also want to remind you, our representative from the city was not able to join us today, but the city cleanup is still happening, and they're encouraging you to put that information that you don't want anymore in your home, put it out on the curb. And then also their last event at a mini station will be today. The Dorp Mall mini station will be servicing and providing vaccines today. And then following today, starting tomorrow, that program will be suspended until further notice. But if you're looking for a place today, you can go to the Dorp mini station that's being partnered in a partnership with the work that the city of Flint is doing. Our time is up for the day. We want to thank you for joining us. We're asking our community health workers and social workers, just as a reminder, to stay tuned and to join, to make sure that you complete your evaluation at the end of this webinar today. For those of you that have joined us today, thank you so much. But please remember to continue to like us on Facebook, subscribe to our YouTube channel, and of course, give us a call at any time at 810-835-2130, or you can email us at info@hfrcc.org. We're looking forward to Jack and Dr. Vega coming back and being with us and sharing more in the future. We want you to know we got a good one for you next week. For join us for session 115 right here for the Flint Community Webinar on coronavirus. Thank you again so much for joining us today.